So welcome everybody. This is the American Society of Addiction Nursing webinar. My name is Susan Blacker. I'm one of the directors at large for ASAN. Happy first day of summer, although to me it's felt like summer for weeks. Okay, this webinar has been approved for one nursing CE through the California Board of Nursing. You will complete the survey sent by email at the completion of the webinar, and a certificate of completion with the CE will be sent by email with verification that the survey has been completed. If you've missed a session, all the sessions are recorded and archived and are on the website, and CE is available for the archives. And you will receive a certificate after completing the survey after you watch the archive. All the webinars are free to ASAN members, so it really pays to join. So keep your cameras on so we can see who's there. Mute your microphone. You can post questions in the chat, or you can come off mute and ask questions. The speaker said that's fine during her talk. So Dr. Marianne Murray trained in addiction studies at Seattle University, then provided mental health and substance use disorder care in an HIV/AIDS clinic during nursing school. While managing a hospital-based detox unit and treatment program for pregnant persons with addictions, she trained other health professionals to provide addiction care. Dr. Murray has worked in residential treatment, rural primary care, a methadone program, and served 8 years at a rural remote community mental health center where she created a medications for addiction treatment program. She currently precepts psychiatric mental health nurse practitioner students from multiple universities in Washington State and beyond.
Thank you. I'll say it again. Thank you so much for joining us this evening. I'm excited to talk about this subject that is near and dear to my heart. Okay, so as Dr. Blacker said, I'm a psychiatric and mental health nurse practitioner. I live in Ilwaco, Washington, on the Long Beach Peninsula, which extends out into the Pacific Ocean. I'm currently at home, 1/2 mile from the Pacific Ocean and just overlooking the Columbia River. This is the most beautiful city that nobody's ever heard of. I'm in a rural, remote area in a county of 21,000 people. It is geographically divided by Willapa Bay, and I am on the Long Beach Peninsula. You can check it out in a map if you so choose. I don't get any money from anybody other than the people with whom I contract to provide my psychiatric services, including in a residential treatment program right now. We will discuss some off-label use, and I may slip and use a brand name. If I do, please forgive me. So I have people that I need to thank for this, because a lot of the material for this comes from a presentation done by 3 colleagues and myself to the American Society of Addiction Medicine on April 1st of 2022. That was an auspicious day, if ever there was one. And yes, the slides are going to be available to people who want them. Somebody sent me that in chat. So my thanks to Dave Cundiff, MD, my partner in working to create Smart Moves Integrated Health Services primary care clinic, which will include primary care, mental health care, and substance use disorder treatment. Dr. Lucinda Grandy in Lacey, Washington. And Cindy has been one of the initial trainers for the buprenorphine training that was required for physicians, nurse practitioners, and PAs until this past year. And so she has been quite the mentor to me and to Dr. Cundiff, who just happens to be my husband. And then Tricia Wright, who is an obstetrician gynecologist at the University of California, San Francisco, and has a lot of experience working with pregnant persons who have addictions. When we presented to the American Society of Addiction Medicine, Mark Greenwald, who is the premier psychopharmacologist on buprenorphine, asked if he could collaborate with us. He was introduced by Dr. Stephen Martin at the University of Massachusetts Medical School in Worcester. So there were 4 of us doing the original presentation, and we created a journal article about it that has been published online just last Friday. It's a review article in the Journal of Addiction Medicine, and I believe it is appearing in the next print copy. Whoops. So here are the learning objectives, as Dr. Blacker already spoke. So how big is this problem? From 2019 until 2021, opioid overdose increased by more than 61,000. In 2021, more than 80,000 people died from opioid overdose deaths, in part because almost everything is contaminated with fentanyl, and in some parts of the country, xylazine is coming into play that does not respond to Narcan at all. Of course, the fentanyl pills that people are buying on the streets are not pharmaceutical grade, and so it's a crapshoot, as people don't know how much fentanyl they're getting, and with every pill they take, however they take it, they're risking their lives. Currently, no fentanyl test strips are FDA approved. You can buy them off the internet, and some of them appear to have very reliable testing. People use them, to see if there's fentanyl in the heroin to avoid it, or they use them to make sure that there's fentanyl in whatever the substance is. Of all of the medications for addiction medicine targeting opioid use disorders, and there aren't very many, there's naltrexone, there's methadone, and there's buprenorphine. Naltrexone is really not very effective for opioid users unless it is in the injectable form under the brand name Vivitrol. Those shots are expensive. They're about $1,800 a month, and insurance companies avoid paying for those if at all possible. The methadone and buprenorphine have very, very strong evidence basis for them. The evidence is stronger for methadone just because it's been around longer and studied more. But buprenorphine has some distinct advantages over methadone, which we'll discuss as we go on. So one of the big problems here that I'm hoping to address with you today is the fact that many providers will limit the doses of buprenorphine to an absolute maximum of 16 or 24 milligrams per day. And that's not suiting the needs of the patients who most must have buprenorphine in order to save their lives. And with the buprenorphine itself, often prior authorizations are required for doses higher than 16 or 24 milligrams a day. Pharmacies keep calling. We have to do creative dosing. So I've had some patients where we've had to get 2 8-milligram films a day plus a 12 and a 4 milligram to get the dose of 32 milligrams. Insurance companies don't like to provide more than 1 or 2 units of the same dose per day. And there is a chain of local buprenorphine prescribers who have a policy that they don't prescribe more than 16 milligrams a day for anyone under any circumstances. But for many people in the age of fentanyl, that leaves them sick all the time. And if people are not feeling well, if they're sick all the time, they're really not interested in staying on the buprenorphine, and they're risking their lives. In the residential treatment program where I spend most of my time now, we have people who come to us from all over the country for our detox and residential treatment program of 30 days, which can extend as needed for people. But we want to have people set up with a buprenorphine prescriber if needed, and primary care, and partial hospitalization or intensive outpatient programs, and mental health counseling as needed when they leave us. And if the local providers are still drinking the cultural Kool-Aid about dose limits of 16 or 24, it's hard for people to get set up with a provider for a higher dose if the only prescribers in their areas are still adhering to the 16 or 24, which is one of the reasons why I'm delighted to be talking with you today about this. So, how do you measure treatment success? Well, you can measure by looking at the reduction in death rates. You can extrapolate to imagine how many people in a given population are using opioids. You can look at how long people remain in treatment, whether it is just medical treatment with buprenorphine or methadone, or if it's psychosocial treatment. But the longer people stay in treatment, the more likely they are to remain sober during that time they're in treatment. Another way that is measured at the Olympia Butte Clinic in Olympia, Washington, which is our state capital, and where Dr. Cindy Grandy was the founding medical director, they look at visit reliability. They actually provide the buprenorphine at the time. Well, people come for a visit 5 nights a week, and at the time that they see the provider, a prescription is written, somebody goes and picks it up from the pharmacy and it's provided to the patient. And depending on how stable they are, they may get a week's worth, but they may just get a few days worth of the buprenorphine with an appointment to come back and see how they're doing. And this works very well when we're titrating the doses. Another measure is using urine tox screens from time to time to measure abstinence from other illicit drugs, because we know that the dose of buprenorphine or methadone is an appropriate dose if people are not supplementing with other illicit opioids. Also, we look at the short-term clinical goals or therapeutic targets, which are oh boy, excuse me, my software wants to update and I do not want it to do that. Thank you. Sorry for the disruption. Long-term clinical goals and life goals. Are people going back to work or going to school? Are they looking to reintegrate in polite society? Have they repaired their relationships with their family and friends? Are they actively living a recovery lifestyle, etc.? So there are arguments regarding the dose limits, pro and con. The people who limit to 16 or 24 say, well, but the FDA package insert says 16 to 24. Well, there's a lot of controversy about that, because even at the time that the package insert was developed, there was already strong evidence arguing for 24 and above for some individuals. There are some people for whom a dose of buprenorphine 2 milligrams a day is quite sufficient. Not very many of them. Most people average about 16 milligrams a day. At our treatment program, the average dose for people who are choosing a buprenorphine pathway is about 28 milligrams. So some people need higher and some people need less. There are questions about, oh, excuse me, I want to say more about the package insert. So there was controversy at the time that the guidelines were developed. And we already had a strong evidence base for higher limits or considering a higher average dose. But the FDA independently decided to publish this, saying that 16 to 24 should be sufficient. Now, we already have a very, very strong evidence base for understanding that in a hospital situation in acute care, med-surg nursing, when opioid analgesics are prescribed for patients like post-op, they are rarely given the full amount. And also for persons of color, they are even less likely to get the full amount or the full max. And I think that translates also in some of the buprenorphine prescribing. Some people say, well, we should limit the dose because there's concern about cost. Others say, well, if somebody's getting 32 milligrams a day, they must be diverting. Well, that's one reason to do the urine tox screens from time to time, because if they don't have any buprenorphine in their system, you know they're not taking it. And if they do have metabolites, okay, so that's good. Another trick that our patients use, and mind you, they are the most creative people in the entire universe. Oftentimes, folks who are not using it appropriately will void into a cup, and they will dissolve a film in the cup so that it will show the presence of buprenorphine. The trick is it doesn't show the metabolites. And so that's one way to know that you've got a screwy urine tox. The other thing for dose limits is expert opinion. And a lot of American medical care is based on expert opinion, or what people have always done or say they do. And often these folks who are providing expert opinion are people who are influencers paid by the pharmaceutical companies to promote their products. So I don't really want to give a lot of credence to expert opinion, especially when the expert opinion is not looking at the needs of the individual patients. So, arguments against dose limits. The American Society of Addiction Medicine is actually trying to get the FDA to change the package insert to reflect the need for higher doses, especially since the age of fentanyl began. There's a great deal of individual variability. Almost all of us are 99.44% alike in our DNA. But there's that little bit of difference that generates a great deal of bioindividuality between people. And we have more receptor occupancy data. Now, some people think that the receptor occupancy should tell us whether a dose is going to work or not for a person. It doesn't. But we know that when the doses are higher, people are more likely to stay in treatment, and they are more likely to reduce their illicit opioid use. There is no analgesic ceiling effect with buprenorphine and with other opioids. And then there's the role of the kappa receptor, which is different from the mu receptor upon which methadone and morphine work. Now, I was going to say something really clever, and I just lost it. But I'll probably think of it, and you may come up with other questions as time goes on. The point is this: we can't just look at lab tests to see how people are doing. We actually have to look at the patient. That's one of the things I love about nursing. It's always been hands-on. We don't just look at the lab tests and decide what a person needs. And we have a tradition also of qualitative research, of listening to people's stories and making sense from them. When people are always feeling sick, meaning dope sick, their doses aren't high enough, they're cranky, they just don't feel right. I want to say something more about diversion. When people purchase buprenorphine on the street illegally or illicitly, usually they're not purchasing that to get high. Now, again, our patients are the most creative people in the universe, and they know how to manipulate this stuff to get high off it. But usually when people are buying buprenorphine on the streets, they are looking to avoid being dope sick. And if there's plenty of buprenorphine available on the streets, and it's still in its foil-sealed pouch for the films, then it's likely not contaminated with fentanyl, and it actually is a public health boon because buprenorphine saves lives. If people are taking buprenorphine to meet their physiologic need for an opioid and not using illicit opioids contaminated with God knows what, they're much more likely to survive the experience. So the package inserts are based on trials from before 2002, and the doses were equivalent to 6 to 24 milligrams a day. They recommended maintenance at 16/4 milligrams for the buprenorphine naloxone product. And the maintenance dose was considered somewhere between 4 and 24 milligrams of buprenorphine a day. It states dosages higher than the 24 have not been demonstrated to provide any clinical advantage. But if you look at the number of people who are taking buprenorphine on a daily basis compared to those who have opiate use disorders and are not taking it, the survival rates are much, much greater. And again, the treatment retention rates. So here's a line that I loved from our journal article. In medicine, we're generally concerned about too high a dose being potential poison, but underdosing can also lead to patient harm. Widespread underdosing of buprenorphine, if responsible for treatment failure, could directly harm many patients whose primary goals are simply to survive and avoid withdrawal. And because the use of fentanyl is frequently lethal, we really need to carefully evaluate any justification for keeping the doses low without looking at the needs of the individual patient. And here is the information on the journal article that I just bragged about. So I want to tell you about one of the first patients I treated with buprenorphine. Joe, not his real name, was a 20-year IV heroin user. He'd not completed high school. He worked intermittently in local industry when he could get his fix. And when I met him at a community mental health center, I offered him buprenorphine naloxone. I started at 8 milligrams every 12 hours because that's what he had been taking when he bought it on the street. I saw him twice a week while we were titrating the dose. When I got to 32 milligrams a day, he was able to work sometimes, but always felt sick. When I got to 36 milligrams a day, with a lot of tremulousness on my part, and the pharmacy calling and saying, "Aren't you prescribing an awful lot of this stuff?" I was the only active buprenorphine prescriber in our entire county. But once he was stable on 36 milligrams a day, which took about a week, he was no longer sick. He was not experiencing any nausea. And he went to work full time doing some pretty difficult manual labor. His wife came in for one of his visits and she wanted to kiss me. She was so thrilled. And Joe was thrilled because for the first time in his adult life, he was able to be the breadwinner in his family. And that 4 milligram difference made all the difference in the world for him. And I want to tell you about Jackie, also not her real name. So one day I was in my office, a patient had failed to show up, and our substance use disorder counselor lead, actually the clinical director, came and grabbed me and said, "You need to see this patient now." So, okay, I went to see that patient. This poor woman had both forearms wrapped in Curlix. She had cellulitis in both forearms, and she had gone to a rural critical access hospital the day before. I looked at her and how much rubor she had surrounding those bandages, and I said, "Yeah, you got to go to the emergency department again, but don't go to the one you just went to because they have not treated you adequately. Go to one that is an hour away, that is affiliated with a major university and has an infectious disease specialist." So she did that. They airlifted her to a population center 2 hours away to a much higher level of care, where she was on antibiotics IV for 4 weeks. Turned out not only did she have this raging infection in each of her forearms, but she also had osteomyelitis in her knee. Now, due to a problem with the phone service, which they were using VoIP, voice over internet protocol, the patient received my cell phone number. And so she called me a bunch of times while she was hospitalized. And one day she phoned me in a panic. "The residents here are telling me that I should get off the Bupe." And I said, "No, you give them my cell phone number and tell them to call me so I can ream them out, because the Bupe is saving your life." But this was quite a few years ago now, and many people didn't know how to dose it or what to do with it. But she got out. She was taking 16 milligrams twice a day, every 12 hours. She was pretty wobbly at first because of the osteomyelitis in her knee, but her gait resolved within 6 months, and she was really stable until she talked about it in a 12-step meeting. And the fundamentalist 12-steppers came out of the woodwork and said, "You're substituting one drug for another. You got to get off that stuff. You're not really in recovery." And she became thoroughly demoralized. So how do we know if the dose is adequate? No cravings anytime, day or night. No withdrawal symptoms anytime, day or night, especially in the 11th hour before they're ready for their next dose. And I do encourage people to try dosing every 12 hours. The original package insert says people should dose once a day. Well, that works with methadone that has a longer half-life, except with folks who are pregnant. But for buprenorphine, most people that I've worked with take it twice a day, and I encourage them to take it about 12 hours apart. If they are treating for chronic pain also, then we need to go to 3 or 4 doses a day, usually equal doses, but sometimes they need to be tailored. Other indicators that the dose is adequate would be no night sweats and no dreams about using. Now, if a person is having using dreams, that doesn't mean that they're fiending to relapse, but it can indicate that their dose of whatever is not accurate or adequate, and that we need to do more for them. And then the 5th indicator is that they're not using any opioid that isn't prescribed for them and known to me as the prescriber. So we recognize that when people have surgeries or fractures or other conditions, they may need other opioids short term. But overall, these conditions hold, and this is the level to which we treat. Now, when I worked in a methadone clinic, there was a lot of talk on the street. Oh, those folks in the methadone clinic, they push the dose so high so people can never get off it. No, we don't do that. We look for the dose at which the person is most functional. So we want to maximize the dose effectiveness and make sure that people are taught how to use this properly. We want them to be really well hydrated so that the films or tablets will dissolve easily. We tell them don't use any nicotine, cigarettes, vape, snuff, whatever, during the 20 to 30 minutes prior to taking the bup dose, because we need vasodilation in the blood vessels under the tongue and in the front of the mouth so that the buprenorphine can absorb properly. So you put the film or tablet under the tongue and tuck the chin to the chest. And the purpose of the chin tuck is to remind them that they're not supposed to swallow this stuff. They're just supposed to let it absorb. And if they're well hydrated, it should absorb fairly quickly. If they have excess saliva, we want them to spit it out. The reason is that little bit of naloxone paired with the buprenorphine can precipitate some withdrawal symptoms. Usually not full withdrawal, but it can be uncomfortable for an hour or so. Some nausea, maybe some gut cramping. So we tell them, spit it out. You're not likely to lose much of the dose of the buprenorphine, if at all. And if people are on the buprenorphine mono product, we still don't want them to swallow it because it is not bioavailable if it is swallowed. So the buprenorphine dose is adequate if a patient perceives that it's adequate and they're not using illicit opioids and they're staying in treatment longer. We have a lot of evidence that 32 milligrams a day is helpful for some people, especially those with chronic pain. And for those who are using fentanyl, 32 milligrams still may not be sufficient. I always ask if they've been buying buprenorphine on the streets. I want to know, how much does it take to keep you from being sick? And often I will start at that dose or slightly below, just because when they're in the controlled environment of the treatment center, they're not going to have to worry about whether they're going to be able to get another dose of it. And by the way, pregnant persons need higher doses of buprenorphine as their volume of fluids in the body increases with progress of the pregnancy. And they also tend to need increased frequency of the dosing. So instead of twice a day or once a day, every 3 to 4 times a day, ideally equidistant, is more in order. So additional considerations for successful use of buprenorphine include ideally splitting those doses 12 hours apart, but adjusting to the needs of the individual patients. Some patients, if they get buprenorphine in the morning, they're nodding off, and that's not so good, especially if people are outside of residential treatment and they're trying to work a job. If we're treating pain, again, we need it 3 to 4 times a day. Methadone has a long half-life, but if we're using that to treat pain, we need to have the patient take it every 4 hours or so. I also caution people about the practical considerations of buprenorphine. A lot of people for whom I prescribe it work in construction. They don't want to leave their bottle in the truck because it might get ripped off. No honor among thieves, and folks who are not solid in their recovery. Well, so it's kind of standard practice that people will put a few films in their wallet and just use that to take their dose at work if they're working long hours, as they do during the summer. But if they're stopped by the police for whatever reason, and they don't have a pharmacy label or a photo of their prescription bottle, they could get picked up for possession, illicit possession. So I caution them about that sort of thing. I also tell people, don't talk about this in 12-step meetings. There are some people who, although they ought not be chastising you, they may. And that can be really deleterious to a person's confidence in their recovery process. I also tell people, don't tell your friends about this. It's really between you and your provider. Family members often will say, oh, gee, I wish you would get off that stuff. It's just switching one addiction for another. So as nurses, we know the difference between tolerance, dependence, and addiction. Tolerance meaning that over time, it takes more medication to achieve the desired effect. We experience that especially with benzodiazepines and long-term opioids. Dependence simply means if you stop it abruptly, you will have a withdrawal syndrome that can be pretty uncomfortable. And we know that happens with any opioid after a week or two of taking it. It also happens with a lot of SSRI and SNRI antidepressants. So there ought not to be any kind of moral judgment against a person taking a medication that has a withdrawal syndrome. And it's not the same as addiction. Addiction involves continued use despite adverse consequences. And usually when people are taking buprenorphine and stable, they're not having the adverse consequences from it. They're cleaning up their lives, taking care of their legal problems, repairing relationships with family members, going back to work, or getting trained for work. And family members' opinions can be so potent about this. It can be really, really deleterious to a person's recovery. Yes, wouldn't it be nice if people didn't need buprenorphine? Wouldn't it be nice if they didn't have the drug problem at all? And in the setting where I work doing psychiatric care, the vast majority of the patients I see coming to treatment are people who have mental disorders that have never been adequately treated or never even diagnosed. The average person on the bipolar spectrum has symptoms for 10 years or longer before being appropriately diagnosed and treated. Now, we still want to use a harm reduction process for people. We don't want to say, yeah, well, go out and use again. But we do know a lot about what helps prevent people from dying of overdoses. And one of them is don't use alone. And this is important for a lot of reasons. Some of the people who die from opiate use disorders and using illicit drugs aren't dying because the dose is too high. They're dying because of postural problems. They nod out, and they are positioned in such a way that it occludes the airway. And it's just postural. If somebody's using alone, there's nobody to rescue them. So ideally, they have a designated driver or a designated monitor. We also prescribe naloxone, better known as Narcan, in the nasal spray for every person for whom we prescribe the buprenorphine. And we want to instruct them and ideally their families also on how to administer the Narcan. Now, usually Narcan or naloxone is prescribed in 2 4-milligram sprays in a kit. And that used to be adequate for most people, but given fentanyl, people may need 6 or 8 or more doses of naloxone in order to retrieve them. Now, a couple of years ago, I used to see news stories, especially in the Midwest and northern United States, about police jurisdictions deciding that they wouldn't use more than 2 doses of Narcan on anyone, which is, yeah, it's expensive, but it's morally unconscionable. Everyone who has a substance use problem is a son or a daughter, a brother or sister, a grandson or granddaughter, or grand person. Virtually every human being matters to someone. And if they're using, especially at a young age, the world doesn't get to experience their unique talents and gifts. So preserving their life is very worthwhile. One thing that does occur with the use of fentanyl is something they call in the vernacular bored chest, where it's possible that their muscles stiffen so much that they can't restore the breathing. The fentanyl is really, really dangerous stuff. And the xylazine that is now seen in some of the eastern states, that doesn't respond to naloxone at all. I advise patients that they should treat an opioid use disorder as seriously as they would if they were diagnosed with a devastating cancer, because the substance use disorder, especially opioid use disorder, is just as deadly, and it can kill far faster. So, especially in treatment, when people are in residential treatment, their families often expect that they're going to go home completely fixed, spun dry, and everything is great. And now they're going to go back to work full time within a day or two, and they're going to resume all their duties of childcare or whatever. But and people may talk behind their backs about the substance use disorder, but most people aren't going to talk to them directly. Whereas if a person is in the hospital for a month with cancer, they're going to be overflowing with casseroles in the refrigerator. They're probably going to have friends help them find wigs. They're going to have friends or family members who drive them to appointments for chemo and radiation and checkups. There's a community of care that forms around people with cancer, which used to be a stigmatized disorder and is no longer. Would that we could get there with substance abuse recovery as well, because when people come out of residential treatment especially, they need that support. And the death rates are higher right after people get out of residential treatment. It's not uncommon for people to be discharged from treatment, use up their existing supply of buprenorphine, not be able to get in to see another buprenorphine prescriber, and just start using again. If they go back to the street drug doses they were on before, where their tolerance might be lower, they're at higher risk of dying. So, if the doses are inadequate, people can die. They're more likely to use. We know the dose is adequate if people think it's adequate, if they reduce or eliminate their opioid use. We'd like it if they would reduce or eliminate their other substance use as well, but I no longer refuse to prescribe buprenorphine for people who might use amphetamine or other things. Instead, I ask, what's that drug doing for you? And how can we get the necessary effect for you pharmaceutically so that you're not putting your life at risk. We also know when the dose is adequate, the buprenorphine dose, people are far more likely to stay in treatment. We have a lot of evidence now that 32 milligrams a day can be helpful for some patients, especially those who have chronic pain. And of course, for pregnant persons, higher doses are needed. So the buprenorphine dose limits don't fit in the age of fentanyl. You got to look at the patient, his or her or their individual life and their needs. And we need to educate them and their families about the value of medication for addiction treatment. And by the way, MAT, it's not medication assisted treatment now. The appropriate nomenclature is medication for addiction treatment, because sometimes the medication is the treatment. Buprenorphine can really save lives. So I have a couple of references for you on some statistics, and there's the journal article I was bragging about, and I'm checking the chat box now. Oh, thank you. Okay, so I want to close the screen share.
Anybody
go
have
back.
any questions for Dr. Murray?
I sure do. I first want to say thank you so much for having this educational session. And thank you so much, Dr. Murray, for sharing your knowledge and your time. I have been on fire before and all during this presentation because I battle this all the time from psychiatrists who are older and refuse. Like even one of my patients was reduced back to 16 milligrams of buprenorphine. But when I had that patient and she was stable on 24 milligrams, she was working, she was engaging in her community, she was taking care of family, sleeping well, not irritable. So now, declining. And I just want to know knowledge based. I'm trying to get them out of that box that 16 milligrams is enough. It's not enough for some people. Evidence-based practice means that I am looking at evidence, but it also means that as a nurse, I'm looking at the whole person and how to get them back to the best version of themselves there is. What can I present to my team to say what you are doing is not appropriate?
Well, it's a big question.
Huge.
So my husband is a public health physician, and he is also board certified in addiction medicine since he met me. And he is on the Council on Science and Public Health for the American Medical Association. He and many of the other members of the American Association of Public Health Physicians are pushing the American Medical Association to make stronger statements about this and to change policy. Also, there is another journal article that came out this past week by David Tyler Coyle, Stephanie Stewart, Cole Bortz, Jane Manalo, Alexis Ritvo, and Martin Kursak. I just got this, titled Buprenorphine Prescribing and Dosing Limits, Evidence and Policy Goals. And this is coming out in the Journal of Substance Abuse. Can you see it? So, two major articles this week. Our review, or in the past week, our review article, and then this one for Coyle. Mark Greenwald's work is excellent. He continues to publish on this, and also Stephen Martin. Remember that as recently as 10 years ago, older psychiatrists thought prescribing chronic benzodiazepines was good medicine for people with anxiety disorders. We know now that it is not, but I do a lot of cleanup. By the way, most of the people who die from opioid overdoses, like methadone patients, they die with benzodiazepines in their system as well. So it's often the combination that compounds the respiratory depression. And concern about respiratory depression is one of the things that spurs people to want to keep the doses low. You get a greater risk of respiratory depression and the QTC interval prolongation with methadone, but you do not get that with buprenorphine. So one of the things to do is work with the younger psychiatrists who have been getting more training. And by the way, I precept for a lot of nursing graduate programs. Some of the FNP and PsychNP programs are now requiring their students to take the buprenorphine training as it was required before they changed the waiver rules in order to graduate. So we are turning out a crop of new, very competent clinicians who know this. I wish I could say that psychiatrists and other MDs and DOs, and I think MD stands for medical deity. My dear husband, it was not an asset in my mind that he was a physician. Well, he turns out to be a really stellar one, and much more attuned to the issues between nursing and medicine than the average person, in part because I keep elbowing him about it, especially when they nurse practitioners and talk about scope creep, which is the AMA's equivalent of nurses and physicians griping about non-compliant patients. Anyway, work from within the field, trust that you know what you know, and educate people and families to as great an extent you can, because the entire country, the entire world needs to know about this. Too many people are dying unnecessarily. And get people off the benzos. Treat their anxiety disorders with an SSRI or an SNRI, and get that in place before you start peeling back the benzodiazepines. Because when people have to come off benzos, they're terrified. They're terrified of the prospect of feeling anxious. They feel anxious that they will feel anxious when they stop the benzos. When I came to this rural community to work in a community mental health center, they had been using locum tenens for 2 years. And I don't want to diss all locum tenens, because some of them do very, very fine work and rescue agencies in trouble. But in this particular one, they'd had a whole bunch of troubled locum tenens, prescribers, nurse practitioners, and there were lots and lots of people on chronic benzos. And I finally learned that I don't say at the first meeting, we're going to have to get you off that. I wait a visit or two until we've at least established some relationship, and then start talking about how I want to treat their anxiety in a more appropriate way. Well, one day, about 8 years ago, I should have circled this on the calendar in gold and put stars and glitter and all kinds of things. 3 people in one day came to me and said, I thought you were the Nazi benzo bitch from hell. I thought you were nuts when you said I had to get off this medication. I thought I needed it so badly. But I got off it over time. Some of them I hadn't seen for a while. Anyway, they said, I can't believe how clearly I'm thinking, how much more energy I have. I'm a whole new person. 3 in one day. Yeah. So there are a lot of people who do not keep up on their education. Each of you, by virtue of the fact that you're here, are creating a different story for yourself and your clinical practice. Keep learning about it, keep reading, keep studying. And I don't know who's calling me, but I need to turn that off. Okay, so yeah, many of us have this problem. And I think the answer is educating ourselves, knowing what the arguments are, anticipating what the problems are. We want our patients, for example, to not have close encounters with police anymore. But knowing that trick about keeping your pharmacy label or a photo of the bottle of the current bottle is really a clever idea, because it can avoid people having to go to jail. And by the way, the National Council on Correctional Health Care, the standard of care now, according to them, is folks with opioid use disorders get buprenorphine. That's the standard of care, but a lot of places are not providing it, or they're providing it just in the few days before they leave, and very little when people are discharged. And in our state, when people are in jail, their state-sponsored health insurance goes away. So it's necessary to have a case manager or a jail liaison who will make sure that they get set up for seamless transition into their health insurance. I didn't mention the injectable form of buprenorphine, which we know has the brand name Sublocade. And I understand that there is another format that is under development. That particular product is injected into the abdomen and it forms a hard disc. If patients don't know that, they get really weirded out by it unless they have diabetes or are on blood thinners and are accustomed to injecting in their bellies. It is very, very difficult to get that for people outside of the urban centers. Many patients who are reluctant to do the sublingual buprenorphine are willing to do the monthly injection, but it's very expensive. It's a couple $1,000s a shot. The pharmacies in rural areas do not want to stock it because that's too much inventory. It's a costly inventory. And insurances don't want to cover it because they're in the business of denying care. And prescribers can provide it if they do a buy and bill program, which means they buy however many, get whatever discounted price they can get. They must keep it in a safe with 2 locks in a locked room. If the pharmacy dispenses this for somebody and that person doesn't come and get their shot, you can't give it to somebody else. And the insurance providers or insurance companies won't guarantee that they will approve it for somebody. So there's a whole lot of financial risk involved for many providers, especially in rural areas. So it's a great idea, but it's not readily available. Other questions?
Yes, I have a question.
Yes.
By the way, I'm in Maryland, and in our county, we have a Bupe bus. We're going to be providing Bupe to our people that are in the county jail when they. So that's I think we're the only one in the state. But my question is about the benzos. So I work in a low threshold environment. We oftentimes get people started on a prescription rather than off the streets. I'm running into people on benzos, a lot of people on benzos, and providers are not big on high doses either. So I'm just curious, when we're advocating for high doses and they're on benzos, do you have a recommendation for a limit dose when they're on benzos? Because I am getting feedback that, well, you can't give more than 16 milligrams if they're on benzos, or I'm not going to prescribe it if they're on benzos. Or understanding they're going to decrease the benzo, in time or switch it. But what's the recommendation?
There's no formal recommendation at this time. Mm-hmm. Here's what I do. I encourage them to accept an antidepressant, an SSRI, or if they're having panic attacks, my go-to is venlafaxine. And I boost that dose. The venlafaxine, I start at 37.5 milligrams extended release. And over a period of weeks, I bump that as high as 300 milligrams until panic attacks go away. And I also provide people with a roadmap of what I am going to do to decrease the benzos. Most of the street stuff out there is alprazolam or Xanax. That's the favorite one. I don't know of any legitimate reason for providing or prescribing that medication long-term. It is the fastest acting, it gives the biggest rush, and it is the one that is most abused. So that should go away. So typically I will transfer people to diazepam, and a dose equivalent. And then I map out how we will decrease that. So I don't decrease the dose equivalent. I give them the full meal deal so that they know that they will not have to be suffering withdrawal symptoms from that and increased anxiety. And then, so maybe I'll divide the dose up 4 times a day or 3 times a day and have, so let's say we're doing 5 milligrams 3 times a day. Depending on how anxious they are about the reduction, I might say, we're going to go to 5 milligrams twice a day and half of a 5 milligram tablet once a day. And you pick the time of day that you are least anxious, and you will do that decrease. And let's hold you there for a week and see how you do. And then we're going to have you pick the next time that you were going to do that decrease. So once I get people where they no longer need 5 milligrams 3 times a day, I will use 2 milligram tablets, and I just write on the prescription, because I may order a lot of tablets, I'll write on there for benzo taper. And when I've done that, I've never had a problem with insurance companies rejecting it, because they like the idea of people getting people off it. But providing a map and showing what it's going to look like. So I do a grid in Microsoft Word and what the dose reduction is going to look like. Now, recently, Suboxone buprenorphine prescriber in our area retired and had a bunch of patients who didn't have access to anybody else for prescribing. And I do have a small private practice, one evening a week. A bunch of people called me, will you come and see me? And one of the people didn't disclose to me until he showed up that in addition to taking 24 milligrams of buprenorphine monoproduct per day, he's also taking 2 milligrams of alprazolam twice a day, plus Klonopin. So 2 benzos and Klonopin. It's an ethical dilemma, because I can't just stop that, or the person is at risk of death from seizures. So every prescription I write says we're tapering, and he agreed to take venlafaxine. We're tapering that up slowly, and we're preparing to do the dose reductions. Now, I don't want to do dose reductions when it's winter, because while in many parts of the country you actually have seasons and you have snow in the winter and the sun shines on the snow and people get light. But here our winters are very gray. We have twice as much rain as Seattle, and in the winter it rains sideways from the breezes off the ocean a half mile away. I do not push dose decreases on antidepressants during the winter, and I also am a lot more lenient about the speed with which I do tapers of benzos during the winter. I don't want to try to push that when a person has had a recent death in the family, or the anniversary of a trauma, or a birth in the family, because those things overstress people. So I want them to know that I appreciate the life circumstances that make people challenging or make life challenging. And I want to see that people are successful. So when the prescription monitoring program came out in our state, and I was working in a methadone clinic, we had to pull a prescription monitoring report on every single patient. And we told them they had to get off the benzos within 2 weeks. Oh my God, people were crashing right and left. It's a nice thought to get them off quickly. Or in our treatment program, we were expected to detox people off benzos in 5 to 7 days. Well, that does not work so well, because people are anxious about feeling anxious. And people might be able to get off the benzos that quickly, but they won't stay off. And if the goal is long-term stability, you need to look at what's going to work for them.
Will you still give the higher dose of the bup while they're still on their original dose of benzo?
I will, because that is more likely to keep them alive than it would if they're using fentanyl.
Okay.
Other questions?
I have a question. I
Yes.
am interested in the team's knowledge about dental effects of buprenorphine, because it's come to my attention that a lot of providers aren't really educating patients about the dental impact. Can you talk to that?
Yes. So buprenorphine can make people far more vulnerable to dental care, or to dental caries. A lot of our patients don't have teeth, or the teeth that they already have or still have pervasive dental caries. But there is now an increasing body of literature about the acidity of buprenorphine and the likelihood of making people more vulnerable to dental caries. And that's especially true when they have habits of using acidic products like soda pop, which is very, very acidic. And so looking at the total picture of one's health, and by the way, the American Medical Association passed a resolution last week, I believe, that acknowledges that dental care is part of health care. What a shock! Who knew?
Finally.
So that should be included in our instructions to patients. And of course, by the time they get to us for any kind of treatment, so many of them have extensive delayed maintenance on their bodies. There are some charities that will provide for people to get new dentures. People who've been running around with 2 or 3 teeth in their mouth, that's the number one thing that prevents people from being employable, is the presentation. So
there is an
also,
FDA warning on that I wanted to mention, because when I realized one of our patients had really severe caries on her remaining teeth and prevented an anesthesia for a surgery that she needed, really created a lot of attention. I remembered hearing that there was that side effect of buprenorphine. So there is an FDA warning, but it says very clearly the risk is worth the benefit, and that they should rinse with water gently after their dose, and then not brush, and then only brush gently an hour after each dose. And I thought that's a lot of hygiene, and it's important to pass that information along.
Yes, it is. And thank you very much for bringing it up. Now, I don't have the time to do this, but I would love it if one of our sisters or brothers here who was creative with software could provide an instruction sheet that we could give our patients about that, preferably something in color that's kind of catchy, because people are more likely to look at it. And oftentimes people will say, I didn't quit drinking, or I didn't do this because my doctor didn't tell me. Well, doctor, nurse can say so and help people improve their overall health. That's one of the things I love about nursing. We do look at the whole person. I often describe Brand X, the MDs and DOs, as providing the cure at any cost, whereas nursing really embraces comfort and quality of life. And continuing that and expressing hope that people can get there. Today, I had an exciting experience in doing a follow-up visit with a patient who has gotten from me a diagnosis of bipolar disorder and gotten stabilized on mood stabilizers, who said that today that she feels like her normal self for the first time ever, and relates to me that as recently as 6 years ago, she was living on the streets of a major metropolitan center. One would never guess by looking at her that that was her background. This is almost like creating a Lazarus syndrome. It's like people are rising from the dead when we get them stabilized on buprenorphine or whatever medication they will take. And that really is the key. The most important medication for addiction is the one that a person will take. If it's buprenorphine, great. If they insist that they want a naltrexone pathway, great. I want them to know that there is not an evidence base for oral naltrexone for folks with opioid use disorders, but there is strong evidence for people who have opioid use disorders who get the monthly injectable form. By the way, when I've injected that, well, I have my rituals about how I do it. I don't mix it until I see the whites of their eyes, and then they wait outside of the injection room while I mix it, cover the syringe with the instruction sheet, and have them sit down. I don't want them to look at it. That is, by the way, a gluteal injection, but it has to be given right away. And about a third of the time, the needle clogs and I have to stick them a second time. They put 2 of each size of needle in the package for that very reason. It's a known problem. And then I massage a little bit after I've done the injection, and people usually do not have discomfort afterwards. So it is important to have so many tools that we can customize to the individual person. When people come in and say, yeah, I've taken buprenorphine before, but that didn't work for me, I want to ask more questions and find out why. If it didn't work because they were smoking it, yes, I will buy that. That's not a good choice for that person. But if they just felt sick all the time on it, then we need to look at maybe going to the mono product. We need to look at boosting the dose till they're no longer sick. We may need to switch from brand name to a generic product because sometimes they can't tolerate the taste of it or the grittiness of the pill or how long it takes to dissolve. So again, we got to look at the patient as an individual and work with their needs.
Can I just ask, I don't know how quick it is, but I did have an important question for us. I'm actually in Washington as well. I'm in Whatcom County at the detox up in Bellingham. And we are seeing, we are starting to see in the last couple months, people coming in who we're pretty sure have the xylazine issues for two reasons. They're coming in with these kind of spontaneous sores that just pop up, and they're not using IV. And we're finding that we've got people, you know, they get to their 24 milligrams of Suboxone and they're still out of their minds. And so the theory is that it must be the xylazine, because what I've heard is that withdrawal is really bad. And what we're finding is that people are leaving. And so I just wondered if you had any ideas about the xylazine withdrawal and how that's being addressed.
So I have not seen anybody on xylazine, and this is the first credible report that I have heard about it in Washington State. So the thing I would refer you to is the psychiatry and addiction line at the University of Washington. They do psychiatry and addiction case conferences from noon to 1:30. I believe it's every Thursday, and always they have really good stuff. Dr. Cundiff, Dr. Tricia Wright, and Dr. Cindy Grandy and I have presented to that, and it was very well received. I'm going to look up to see if I have the phone number, because they also have a consultation line. Okay. And when I have been really stumped with what to do for a psychiatric patient, for example, whom I've not been able to stabilize with their psychosis, I can call, and within an hour, I will get a call back from a psychiatrist who will help me out.
Okay.
Okay, so I'm looking up psychiatry and addiction. Consultation line is area code 874-927-7924. And a lot of the physicians who staff that are also people who are part of the Psychiatry and Addictions Case Conference. That's led by Rick Reese, who is the lead psychiatrist at Harborview Medical Center, and he is author of many textbooks on addiction, or he is editor and co-author. And Mark Duncan also takes the lead on that.
So when you call, you're obviously not talking to the actual physician. You just you
will get a call back, usually within an hour, day or night.
Okay.
And you'll be talking to a real person who's usually pretty knowledgeable.
Okay. I will say that the xylazine is coming up from Seattle. And likely. We're getting that firsthand. So it's, pretty big up here now.
Thank you so much, Dr. Murray. I think we're out of time.